At this year's ASCO, we presented the data of BR in combination with Idelalisib compared to BR in combination with placebo. And we figured out with a longer follow-up that the median PFS was 23 months, which is really good for all comers. What we also saw is that in patients with 17p, the median progression-free survival was much shorter, about 16 months, which is really a big difference from what we were expecting, knowing that you could achieve similar results just with Rituximab instead of including the Bendamustine. So a lot of people are asking, why is this? Most of us that participated in the clinical trial looked at the data, and we feel that part of it is that many more patients acquired an infection or toxicity that led to discontinuation of the drug. So if you are no longer able to take the drug because you have a side effect, then you're going to relapse sooner. That's one of the possible explanations, particularly because many of these patients had received prior chemotherapies that may have led them to be a little bit more immunocompromised and susceptible to develop these side effects. The other possibility is that maybe the 17p deletion, because the chromosomes are more unstable and they are a more aggressive clone, may lead to a more resistance, overcoming the fact that even though they are on a drug like Idelalisib, you give them another drug like Bendamustine that can cause changes or clonal selection faster than the oral drug that may have led to an earlier relapse in these patients. For comparison, even though you can never compare study head-to-head because there's never been a comparison, at least what we know from long-term follow-up of patients treated with ibrutinib monotherapy, the median progression-free survival for those patients was 28 months. So if you have 17p, my clear choice would be, at this moment, ibrutinib. Now in the United States, we also have the approval for venetoclax, so depending on the patient's comorbidities, the ideal sequence for a patient with 17p would be frontline ibrutinib, and at the time of disease progression or due to undue toxicities, they could be salvaged with venetoclax, and then maybe consider a drug such as Idelalisib.